Thank you, sir. At the outset, none of the authors have any financial disclosures to make. So, it's not moving. So why as refractive or corneal surgeons, we need to understand or study the collagen? We already have multiple topography, biomechanics, and OCT-based indices, which helps us to differentiate normal from suspect corneas. However, we do come across cases where topographies and biomechanics are normal, but sometimes topography and biomechanics don't match at all. And there are times when a patient with normal topography and biomechanics land up developing ectasia and vice versa. So what is happening here? What are we missing here? Our group has published in the past that patients with normal topography and biomechanics who landed up developing ectasia had pre-existing lower levels of collagen in eyes developing ectasia. So collagen fibrils are nothing but they provide the biomechanical prerequisite which is necessary to sustain the shape and provide strength to the cornea. So answer was collagen. But at this point of time, the only way we can measure or know the collagen level is to excise the corneal tissue, but it is not a practical option. It is challenging, and of course, it is invasive for normal patients. So our research question was, is there a non-invasive way to study the collagen fibril orientation and distribution, and can we translate this knowledge into clinics for screening of refractive surgery patients and choosing the right procedure? Polarization sensitive light has been there in ophthalmic practice for more than 10 years now. So we use the same light, polarized sensitive light, and developed an OCT where the polarized light is projected on the cornea. All the layers of the cornea will take up this light, but the stroma will show the bifringence property and refract the light. So we took advantage of this property and developed our custom built polarization sensitive OCT, which had an added advantage compared to the commercialized OCTs. They had a maximum detector bandwidth which was higher than others. The full depth in pixels and the pixel resolution was also much higher compared to the other OCTs which are already in practice. So what information it gives us? It gives us epithelial maps which are of 11 millimeter zone, which are not extrapolated like the existing OCTs. It gives us the Bowman's thickness, whether it's normal or whether it's thin, because a thin Bowman's membrane can, if you do a surgery on these patients, they are unable to maintain the integrity of the corneal structure post-surgery or because of any trauma. So this is the first ever tool to quantify the Bowman's layer thickness. This is how the collagen distribution looks like theoretically, and the colored maps, what you are seeing here, comes from the polarization sensitive OCT. To simplify, the denser the blue or violet the color, that means the denser the quantity of the collagen is and the orientation of the collagen is in that area. The lighter the blue, that means weaker the collagen is in that area. So this is how a normal looks like. And in a formfrust keratoconus and in a keratoconic eye, you'll see partial loss of orientation and arrangement of collagen. And here you'll see a complete loss of orientation and arrangement of collagen in these eyes. We also have developed in this machine that where you can also see the orientation. Ideally, it's perpendicular to each other, but whenever there is a suspicious topography of early formfrust keratoconus or a keratoconus case, the perpendicular alignment of this collagen fibers start getting distorted and which can be studied. So in addition to density, you can also study the alignment of the collagen fibers. Now, how does PSOCT helps us in identifying the suspicious cases? We have designed the study with 535 normal patients, 349 suspicious cornea patients, and 337 clinical keratoconus patients. They underwent detailed clinical evaluation, corneal topography, biomechanics, epithelial mapping, and in vivo collagen distribution imaging using custom-built PSOCT. So these are two case examples. Case 1 has a suspicious looking topography and suspicious indices. Case 2 is a normal topography with normal indices. However, after refractive surgery, the first patient is still doing well, whereas the second patient, where everything was normal, has developed ectasia. Fortunately, we had done a polarization sensitive OCT when we developed this machine for this patient. And on retrospective analysis, we found that the first patient had a healthy Bowman's membrane and a healthy looking collagen and distribution. However, the second patient had a thin Bowman's membrane and a complete loss of orientation and arrangement of collagen, which could have probably led to ectasia in this patient. So looking at this, we developed a nomogram where we divided these patients into 4 groups. The first group had normal density of collagen and distribution with a thick Bowman's membrane. The second group had normal collagen distribution but a thin Bowman's membrane. The third group of patient had abnormal collagen distribution but a thick Bowman's membrane. And the fourth group of patient had weak collagen distribution and a thin Bowman's membrane. Based on this, the first group of patients received refractive surgery based on surgeon's preference. The second group of patients, for low dioptric correction, they received a SMILE extra or a PRK surgery, and the patients with high refractive error received a phakic IOL. Similarly, for group 3, the lower dioptric patients received PRK extra procedure, and the higher dioptric correction patients received phakic IOL, and the fourth group also received phakic IOL. We also studied how the post-refractive surgery patients behave, and we found that there was nil to minimal change in collagen distribution patients post-PRK surgery, followed by SMILE and LASIK. So this is the first polarization-sensitive OCT in the world which is used in clinics to study the orientation and arrangement of the collagen fibers. It helps us to differentiate healthy from suspicious corneas, and because suspicious corneas do reveal a unique distribution of collagen, indicating early changes before their topographic manifestations have started. So it can be included in our refractive surgery screening in future as we go on. So we have now developed indices. We have got the regulatory approval through which we can commercialize this PSOCT in practice. We are also using it for retinal imaging, glaucoma imaging in our practice, and we are incorporating the confocal microscopy imaging in the same tool. Thank you.
Very nice, Pooja. But I saw that you have compared this with biomechanics also. So did you find a correlation between the collagen arrangement and biomechanics? Did it correlate? So if you find a red flag on biomechanics, will you get a different arrangement on collagen?
Yes, sir. So what we have found that the more than CBI and TBI, SPA1, which is the stiffness parameters, has a better correlation with this collagen fibril, because that's the true stiffness parameter where it negates the scleral biomechanics and only gives us the true corneal biomechanics. So we do have found a correlation with it, with which we have developed another nomogram, but that needs validation. So maybe for
now this machine nobody in the world has.
So
this is your original work, right?
So this is an original work, and before we presented, so when I submitted this abstract, it was not, it was approved by regulatory body, but not for commercialization. But recently, a company has taken it over, and they are going to commercialize it once they have approvals from their end. So it's going to be commercialized soon, and it's going to be one of the companies which is dealing with topographers and biomechanics.
Very nice.
So they have already taken it up.
Just one question in terms of how did you validate the thickness of Bowman's layer? What your machine measured and what is the actual measurement?
Sir, so when this machine gives us a high definition OCT, so where you can actually indent the Bowman's membrane and you can quantify it manually, and it also you can correlate it with the software. And what is the normal thickness, what is the thin Bowman's membrane thickness is based on the literature. So if it's less than 15, the average is 14 to 18. If it's less within that range, it's normal, but below 14, it's thin Bowman's membrane, which is based on the literature thickness.
No, what I meant was what your machine has given a measurement, and if you take the cornea and do a histopathology and actual do a measurement, did you have correlation between the two?
So that is yet to be found, but the correlation of the actual Bowman's thickness comes from the literature, where they have done the histopathological evaluation of the Bowman's thickness.
Yeah, because this is the only device you have. There is nothing else that we can use to compare. So I think that also validation is important because you are basing a lot of your suggestion based on thin or thick Bowman's layer.
Yes, sir. Thank you.
Very good.